Welcome all in the today's session. So basic concept in cystic fibrosis in pregnancy, it is a genetic defect is there in the CFTR gene, that is cystic fibrosis transmembrane conductase regulator gene. So CFTR, cystic fibrosis transmembrane regulator gene. It codes for chloride channel protein. It is located on chromosome 7, and there is a defect which is there. It reduces the chloride transport. That is why the secretions, the body secretions become the thick and the viscid. Okay, so it affects the lungs, leading to bronchiectasis, pancreas. There can be insufficiency of the pancreatic enzymes, and reproductive tract. It can cause infertility in the male. Okay, so it is a genetic condition. So what is the type of inheritance? It is an autosomal recessive. So CFTR gene, which is located on chromosome 7, is defective. Then it decreases the chloride transport. That leads to the thick viscid secretion. Organs which are mainly affected are the lungs, pancreas, hepatobiliary, and reproductive tract. Okay, so you will have symptoms related to this: lungs, pancreas, hepatobiliary, and reproductive system. And infections are common in these patients. So which organisms are involved? Pseudomonas aeruginosa, Staphylococcus aureus, and Burkholderia cepacia. Okay, so Burkholderia cepacia, these are the organisms which are common, and main cause of death is the respiratory failure or bronchiectasis. So that is the common cause of death in patients with cystic fibrosis. Okay, so what are the systemic complications which can happen in these patients? There can be pancreatic insufficiency, there can be diabetes related to cystic fibrosis, that is CFRD, then liver disease, osteoporosis, and gallstones. So pancreatic insufficiency, cystic fibrosis related diabetes, liver disease, osteoporosis, and gallstones. These things can happen. Okay, now coming to the fertility aspect of these females in cystic fibrosis, what is the effect of on fertility? So in females, generally the fertility is near normal, or you can say subfertile, but not infertile. Okay, so in females, it is a near normal fertility. The thick cervical mucus is present, but well, in males, it is almost always infertile because of the bilateral absence of the vas deferens. Okay, congenital vas deferens. Okay, then menstrual features, there is a delayed menarche, mainly because these patients have low BMI. There is amenorrhea. There is a poor lung function also. Okay, then coming to the contraception, most commonly use the COC, but it reduces the efficacy of the antibiotics. These patients have a very common requirement of the antibiotics for various infections, especially respiratory infections. So there is a decrease in the efficacy if the of the oral contraceptives if the antibiotics are used, and these patients require a frequent use of antibiotics. So along with COC, they will use additional barrier method. Okay, then other LARC that can be used here are Mirena, Implanon, etc. Then Depo-Provera. Alexa, stop. Then next is a Depo-Provera. It may worsen the osteoporosis. Okay. Then what is the effect of cystic fibrosis on pregnancy? The fetal outcome, the live birth rate is 70 to 90% of cases. Miscarriage rate is same as that of the general population. However, prematurity rate is increased almost 1 in 4, that is 25% case chance of prematurity. Congenital anomalies are not increased. Okay. So maternal issues during pregnancy are the poor weight gain. These patients have poor weight gain, 5.5 to 10 kg, that much weight gain generally these patients achieve rather than expected 10 to 12 kg. There is a malnutrition that will lead to the miscarriage and preterm birth. There is an increased chance of diabetes, at least 1 in 5, that is 14 to 20% patients can have diabetes, and that further will increase the risk of the stillbirth and the preterm. Okay. Now, effect of pregnancy on the cystic fibrosis. So what we have seen, what is the effect on now we will see the effect of pregnancy on the cystic fibrosis. So pregnancy does not significantly reduce the survival overall. So there is no not much effect or the long-term survival of the patient. Okay, so basically which factors are important? There should be good lung function. When we talk about good lung function, means if the FEV1 is more than or equal to 70%, the outcome is best. Okay, so pulmonary function tests are going to be very important. FE1 should be more than 70% or equal to 70% for the best outcome. If there is a poor lung function, there is a high chances of maternal mortality. FE1 less than 50%, there is a higher risk and relative contraindication for the pregnancy. If there is a pulmonary hypertension or cor-pulmonary, again it is an absolute contraindication for the pregnancy. And if there is a infection with Burkholderia cepacia, that is also a relative contraindication for the pregnancy. Okay, so important figures will be 20% mothers do not live to see the child's 10th birthday. Okay, so 1 in 5 mother will not see the child's 10th birthday, and this mortality will be increased if there is a poor lung function. So it will be increased to 40%. Okay, if there is a poor lung function. That is why FEV1 is going to be the most important parameter in these patients. Now, this question is going to be very, very important. This the risk of transmission. You have one question from the genetic always, especially in paper 1 or paper 2, between question number 30 to 40. Somewhere you will find this particular question. So this is an autosomal recessive condition. So if the mother is affected and partner is not a carrier, in that particular case, what is the risk of the child being affected? It is 1 in 250. Still the child can have affection. All children will be carrier. So this we will see subsequently. So when the mother is affected and partner is not carrier, that means partner is normal, then being autosomal recessive, almost every child is going to have this, and all children ideally should be carrier, but still there is a risk of 1 in 250 carriers, because even if we test the carrier, not all mutations will be tested. Okay, only specific mutations will be tested. So there remains a risk of child being affected, which is 1 in 250. However, theoretically, all children should be carrier only. Okay, but there are many mutations, so we do not test all the mutations. So the possibility of still the partner being non-carrier, there is a possibility of the 1 in 250. Okay, if the mother is affected and the partner is carrier, then there is a 50% chance of the child being affected. So such kind of questions are asked, and there is always a one question on the genetic. Okay, so it is an autosomal recessive disease. Disease occurs only if both alleles are defective. So if we label this as a small a and a, the carrier will be denoted as a capital A and small a, which is asymptomatic. Okay, now we have case where the mother has got a cystic fibrosis. So we are labeling this as a small a, small a. So she will always pass a allele to the child. Okay, so mother has got this genetic composition, small a, small a. Partner is not a carrier, so it is AA. So mother has got, mother's gamete will be denoted as a small a, father will be denoted as a capital A. So all children will be carrier in this particular case, no affected child. But what happens in real life? Carrier testing is not, carrier testing does not detect all mutations, and still there is a residual risk which remains. That is why hence the risk which is quoted is 1 in 250. Okay, so ideally there should not be any affected child, and all children should be carrier. But still in real life there is a 1 in 250 risk of the having the child when mother is a carrier and father is a normal, because all mutations are not tested. Okay, now second scenario, mother is a affected, okay, and the partner is a carrier. So if the mother is affected, which is small a, small a, and the partner is a carrier, that is capital N, small a, in this particular case there is a 50% children will be carrier and 50% will be affected. Okay, so risk of affection is 1 in 2. And when you read these questions on genetics, please go through all the options. One option in this scenario will be 50% will be affected. So that option will be there somewhere, option number 3. But there may be another option, 50% affected and 50% carrier. So best option will be 50% affected and 50% carrier. So your answer is partially wrong if you just say 50% are affected. Okay, so read all the options carefully. It is a EMQ question. Okay, is it clear, doctor?
Yes, sir.
Yeah. Okay, so why all children are carriers? If the mother is small a affected, that mother will always give allele to every child. Okay, so that is why all children will be carrier in that particular case. So when the mother is affected, everything will depend upon the father, whether father is normal or the father is carrier. If the father is normal, all will be carrier. If father is a carrier, then 50% children will be carrier and 50% will be affected. Okay. So just remember this particular table. Mother affected, father normal, there will be 100% carrier. Practically, there is a 1 in 250 residual risk. Okay, ideally 0% affected. Okay, but practically 1 in 250 still there is a risk. Mother is affected, father is a carrier, so 50% will be affected. So 1 in 2 will be affected. Okay, mother is a carrier, father is a carrier. This is autosomal recessive disease. So 25% chance of affection, 1 in 4. Okay, so please remember these calculations. So autosomal recessive disease and one parent affected, risk will depend entirely on the partner. Okay. So carrier frequency matters, 1 in 25 in the population. So in general, there is a 1 in 25 frequency in the population. Hence, screening is essential. Okay. Now, what about the pre-pregnancy counseling? So key components are the lung function, okay, is the most important. FEV1, the nutritional status of the mother, and whether she has got a diabetes or not. So these are the parameters which you need to see. What is the lung function? What is the nutritional status, diabetes status, and partner genetic testing. We will discuss the maternal prognosis and the parenting challenges. Offer the CVS for antenatal diagnosis. Pre-implantation genetic diagnosis is to be offered. Okay. So antenatal management is a multidisciplinary management, and the multidisciplinary team will consist of cystic fibrosis physician, obstetrician, dietitian, physiotherapist, diabetes team, anesthetist, and the midwife. Okay. So nutrition, high calorie diet, and if required, enteral feeding you may have to offer. Okay. Lung function, regular monitoring is to be done. Infections, aggressive treatment is required. Maybe IV antibiotics also. Diabetes, you have to screen these patients in the first trimester. Plus, you will repeat the screening between 24 and 28 weeks of gestation. This is most important. Either they will be known diabetic. If they are not known diabetic, you will screen them in the first trimester, and you will repeat screening between 24 and 28 weeks of gestation. And for fetal growth, you will do the serial third trimester scanning. Okay. So most of the cystic fibrosis drugs are safe during the pregnancy, and we will always prioritize the maternal health. So what is the mode of delivery? Mode of delivery will be decided by the obstetric indication. So vaginal delivery is not contraindicated. It is preferred if the mother is stable. Cesarean section rate is high. It is around 31%, but mainly it will be preterm for some associated comorbidities. And instrumental delivery is common, and that mainly because of the maternal fatigue. Okay, preterm delivery if there is a maternal deterioration. Anesthesia. Which kind of anesthesia? It is better to have epidural. It reduces the fatigue, helps in prolonged second stage of also. Even if the prolonged second stage is there, epidural will help. Regional is preferred if possible. If there is a severe lung disease, then general anesthesia. Breastfeeding per se is not contraindicated, but there may be high caloric demand and maternal exhaustion. The composition of the breast milk is normal, and we have to take into account the nutritional status and drug safety, okay, while breastfeeding. Then post transplant pregnancy, you have to wait for 2 to 3 years for the pregnancy. There is a risk of prematurity and the graft rejection. So what is the take-home message? Take-home message: cystic fibrosis is an autosomal recessive condition, chromosome 7, and CFTR gene, that is the defect. Most of the men will be infertile, women will be subfertile. Pregnancy usually is safe if the FEV1 is more than or equal to 70%. If there is a pulmonary hypertension, there is an absolute contraindication. Generally, there is no increase in the congenital anomalies. Prematurity rate is around 25%. Cystic fibrosis related diabetes is common, 1 in 5, around 14 to 20%. 20% maternal mortality before the child becomes 10 years, and it will be increased to 40% if there is a poor lung function, and multidisciplinary care is essential. So this is what is the take-home message from this talk article. Now we have certain SBS. Doctor, can you please read the SBS?
Yes, sir.
Yes,
A
please.
28-year-old
Uh,
a 28-year-old woman with cystic fibrosis is planning pregnancy. Which factor best predicts a favorable maternal outcome? A. BMI more than 80. B. FEV1 more than equal to 70% predicted. C. Absence of diabetes. Age less than 30. E. No prior pregnancy. It will be FEV1 more than equal to 70% predicted.
Yes. FEV1 more than or equal to 70% of expected is the
Mhm.
correct answer. Lung function is the single most important predictor. FEV1 more than or equal to 70% is will have the best outcome and lowest maternal mortality. Question 2, doctor.
Yes. Which condition is an absolute contraindication to pregnancy in cystic fibrosis? A. FEV1 less than 50%. B. Cystic fibrosis related diabetes. C. Pulmonary hypertension. D. Low BMI. E. Chronic pseudomonas infection. It will be C. Pulmonary hypertension or core
Correct.
pulmonary.
Yeah. Pulmonary hypertension. Okay. If there is a pulmonary hypertension or core pulmonary, it will have a very high maternal mortality. That is the absolute contraindication. And there are certain relative also, like if you have a Burkholderia, Cepacia infection and all. Okay. Next.
A pregnant woman with cystic fibrosis has increased risk of which complication? A. Congenital anomalies. B. Macrosomia. C. Prematurity. D. Polyhydramnios. C. Placenta previa. It is C. Prematurity.
Yes. Prematurity around 25%, 25 to 30%. Okay. So prematurity is around 25%. Congenital anomalies not increased. Next.
Yeah. Which organism is associated with poor prognosis in cystic fibrosis pregnancy? A. Staphylococcus aureus. B. Pseudomonas aeruginosa. C. Burkholderia cepacia. Or D. E. coli. E. Klebsiella. It is C. Burkholderia cepacia.
Yes. So cystic fibrosis, you remember this Burkholderia is common. Okay.
High
Burkholderia
mortality
cepacia
rate.
associated with high maternal mortality, relative contraindications
Relative
to the pregnancy.
contraindication.
Okay. Next.
What is the most appropriate screening for diabetes in pregnancy in cystic fibrosis? A. Random glucose once. B. HbA1c only. C. OGTT at booking only. D. OGTT in first trimester followed by 24 to 28 weeks. E. No screening required. It is D. OGTT in first trimester followed by at 24 to 28 weeks.
Right. Absolutely correct. So OGTT in the first trimester and repeat at 24 to 28 weeks. Cystic fibrosis has got a high risk of diabetes, requires early plus repeat screening if the initial screening is normal. Next.
A woman with cystic fibrosis is on combined oral contraceptive pills. What advice is most appropriate? A. Stop COC. B. Switch to barrier only. C. Add barrier method when on antibiotics. D. Double dose of COC. E. No change needed. C. Add a barrier method when she's on antibiotics because
Yes,
it
this point
decreases
is
the
important from
efficacy.
your FSRH point of view as well as from this cystic fibrosis point of view. So add barrier method when on antibiotics. Antibiotics will reduce the efficacy and that is why additional contraception is required. Next question.
Which statement regarding fertility in cystic fibrosis is correct? A. Both sexes infertile. B. Females infertile. C. Males infertile, females near normal fertility. D. Fertility unaffected in both. E. Ovulation absent. It is C. Males are infertile, but females are having near normal fertility.
Correct, correct. So males are almost always infertile. Females will be relatively having preserved fertility. Next.
A cystic fibrosis patient has a poor weight gain in pregnancy. What is the next best step? A. Ignore if the fetus is normal. B. Start the insulin. C. Enteral nutritional support. D. Early delivery. E. Steroids. It will be enteral nutritional support.
Yes, you have to think about enteral nutritional support in these patients. Okay, so nutrition is critical determinant of the outcome. So nasogastric feeding, jejunostomy, if required, you may have to think of. Next.
What is true regarding delivery in cystic fibrosis? A. Cesarean always required. B. Vaginal delivery contraindicated. C. More depends on obstetric indication. D. Instrumental delivery is contraindicated. E. Always preterm delivery. It is the more depends upon the obstetric indication. C.
Yes. Option C, more depends on the maternal condition, obstetric factors. Vaginal is preferred if mother is stable. Next.
Which statement is true regarding long-term outcome? A pregnancy reduces the survival. All women survive to see child adulthood. 20% die before the child is 10 years old. Mortality is negligible. Only severe cases are affected. It is C, 20% die when before the child is 10 years old.
Yeah, and it may be 40% also if she has
40%.
got a poor lung function. Okay. So if
Yes.
the poor lung function, it may be increased to 40% also. So that finishes the talk on cystic fibrosis in pregnancy.